Hello everybody, this is Dr. Craig Thomas and welcome to CE Wire 2017. We're going to have a nice course today called Color Vision in Health and Disease. We're going to talk about color vision testing, all the diseases that can affect color vision, and how do we take care of our patients with these problems. I do have a couple of financial disclosures. I am a paid consultant for BioD and for Conan Medical. I will be mentioning some of Conan Medical's products today, but I will try to be fair and objective as always. Let's begin. Clinical indications. Whenever I talk to optometrists about color vision testing, the first thing I have to do is to make sure we're talking about the same thing. And almost always the initial thought is that we're talking about pulling out a plate of Ishihara color vision testing plates and trying to screen someone's color vision. That is not what we're getting ready to talk about. And the diseases that we will use color vision testing to manage are not regular type things that we were taught in optometry school. These are the clinical indications that I have used when I try to help my patients and determine if they have color vision defects and what's causing them. You of course can have the congenital color vision deficiencies that we all learned about in optometry school, but you also have all of these other things that cause acquired color vision deficiencies, and that's what we're going to spend most of this presentation talking about, is acquired color vision defects that happen in adult patients, not congenital or genetic defects that happen from day one. As a review, we need to talk a little bit about the principles of visible light. This goes back to our beginnings, almost first year optometry school and first semester optics. I pulled out my old optics textbook for a minute and some of my old high school physics books actually to get some information just to review myself. And this is what I thought was pertinent. I'm not going to read slides to anybody. Everybody can read. Just to remind everybody that, that light is energy, part of the electromagnetic spectrum. Light has different properties, the wavelength and the energy, and these properties can create visible light as opposed to, in addition to invisible light. And you see the color bar demonstrating how the different wavelengths produce different colors. So this is all review. I just wanted to pop it up here so we can start with this, but let's quickly move on. Normal color vision. Remember that color is perceived because the object selectively absorbs certain wavelengths and then transmits another wavelength. And the object takes on the color of the wavelength that it transmits. So something that we think is blue is transmitting a blue wavelength of light. It's absorbing something else. The perception of color, and this is, we won't talk too much about this, but just so we can say we touched on it, the perception of color is defined by three variables: the hue, the saturation, the brightness. We could go into excruciating detail and talk about different color models and things like that. For the sake of this lecture, I don't think that's necessary. I just want to give you some basic terms and basic review about light and energy and color vision. So here we are. Just remember those three terms: hue, saturation, brightness. Those are the three variables that define color. And when we're talking about normal color vision, because again, the title of the lecture is Color Vision in Health and Disease. Well, the first thing is you've got to see color vision when it's normal to have some reference point to compare color vision when it's not normal. So remember, color vision is a function of the cones, and the three cones have responsible for different wavelengths of light in the spectrum. And most of us, people with normal color vision, we require all three colors to match the colors in the visible spectrum, the three primaries: red, green, and blue. If you have all those three in the proper proportion and you have normal color vision, you're called a trichromat, the tri colors. So trichromat, most of us are trichromats. To make this make sense, you've got to review and understand the neural response of the visual pathway. How do we see? How do we see normal stuff? How do we see color? What's called chromatic sensory information. Most of the time the vision is going to start with our receptors, the photosensitive rods and cones, and they detect light, and then they encode the initial neural response, and it turns into an electric response. And you see this circuitry almost like electrical wiring. The circuitry starts here in the retina with the rods and the cones, the receptors, and then goes back along the optic nerve. You can see the cursor here, and crosses over into the visual pathway going to the lateral geniculate nucleus and to the back of the brain and the visual cortex. So this is the circuitry for color coding, and just like with all other aspects of our vision, some of the vision that we transmit is chromatic, some of it is not. This is how the vision information is transmitted. So the neural response of the pathway. We have the second stage, the transmitters, which is the optic nerve, the chiasm, the optic tract, lateral geniculate nucleus, the optic radiations. And these are organized really in a linear fashion in these parallel ganglion cell systems. We've got three divisions, three different tracks, so to speak: the parvocellular division, the magnocellular division, and the coniocellular division. Again, you can see from the bullets, the parvocellular is responsible for the majority of our color vision transmission. It transmits the red and the green. The red and the green cones are connected with the parvocellular division. The magnocellular division, which we usually talk about when we're talking about glaucoma, is achromatic and does not transmit any sensory information. The coniocellular transmitting the blue-yellow, and you see this significant difference there, where only 2% of the fibers and the cones are responsible for transmitting blue-yellow vision, where you have all 98% responsible for the red and the green. And that differential is kind of demonstrated here. So this is a representation of normal retinal cone distribution. You can see the overwhelming number of red cones followed by the green to a lesser degree, and the occasional blue cones scattered around. So it kind of gives you an idea of what we're dealing with. And this image will let it make sense down the road when we see why it is so common and why it is so often that we have blue-yellow color deficiency when we have disease. You see there's so few blue cones that it's pretty easy to damage enough of them to affect your color vision. So this is what the normal retinal cone distribution looks like. The last step in this neural response of the visual pathway is the signal going through the lateral geniculate nucleus and then to the visual cortex. And we've got this nice schematic here of the lateral geniculate nucleus, and you can see the different divisions. The parvocellular division is represented by the P, this first dark band here, 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 and here. This is the parvocellular division, these bands right here. The magnocellular is these bottom two bands here and here. The coniocellular division is made up of this white small membrane or tract or slab, whatever you want to call it, division. This white stuff right here, what looks like this white ground substance, that's the coniocellular division, and there's a piece of that between each little slab here, and that's what's transmitting the blue-yellow vision. So interesting to remember and important to know as we get into it when you're trying to figure out what's going on and where's the site of the damage. It's important to know how this is organized, these retinal cortical pathways, how they're organized and then reorganized as they go through the lateral geniculate nucleus. Let's talk about the stuff that we were trained on in optometry school, which is almost exclusively genetic color vision defects. I went to optometry school over 30 years ago, and this was the bulk of what we were taught. And then we had maybe a day or two on something called Kohler's rule, where we talked about how optic neuritis can give you a red-green defect and things like that. But it was very minimal. I remember it was not intense at all, and we only spent a few days on it out of a 4-year curriculum. So as a quick review, let's talk about our genetic color vision defects. So these are people with an inherited cone pigment abnormality, and that produces a decreased sensitivity to one of these three primary colors. And these people are called anomalous trichromats, whereas again those of us with normal color vision are called trichromats. And you'll see the terms that we're all familiar with: protan deficiency, indicating red cone pigment is low; deutan, the green; and tritan deficiency, the blue cone pigment is deficient. And remember that anomalous trichromats are not colorblind. They can see color, it's just different. And so they use different cues and different keys to kind of tell what the colors are because they're consistent. It may not be the same red that you or I see, but it's the same red to them every time they look at it, so they learn that it's red. So people that have color deficiency almost always have some color vision, but it's not normal, so they have a color matching deficit. So they're not colorblind. We really shouldn't use that term. Color blindness is a very rare condition. They're color deficient. We all learned about the prevalence of color vision defects, genetic defects, congenital defects. What we all learned, and this is review, and it hasn't changed really. Young males of North European ancestry, young white males, you've got about an 8% chance of having some kind of color vision deficiency. Most of the time it's deutan, and every once in a while it's protan. And you have an extremely small number of females that have the same defect, about a 0.5% or less. So this is primarily a male problem, as we've all learned. And it does hold true for males of all races, but there does appear to be some racial difference where white males appear to be disproportionately affected compared to males of African or Asian ancestry. But red-green color defects do affect males of all races disproportionately compared to females. So there's your breakdown here. Our blue-yellow defects, which are not X-linked, are exceptionally rare. Again, the percentages are almost not worth messing with. And most importantly, the stuff that we were taught where they made us all buy an Ishihara color vision plate book, 30 years ago, it doesn't test for the trytan deficiency that we are looking for most of the time. So you can't really depend on those things to make any decisions at all. What we use now, what I use, and what I'm recommending that you use if you're not using it now, is some type of computer-assisted testing. So there's a couple, 3 or 4 different products on the market. I'm going to just touch on 2 of them because I don't want to be product specific. I just want people to start doing computer-assisted color vision testing. Okay, I don't care what you get something. I think what I'm going to show you is good, but get whatever you want. The first thing is a computer-assisted software program called ColorDX, and you load it up on a tablet or you can put it on a computer. You see what it looks like here. This little kid is using the tablet and doing the test. And this is so cool for the kids. They like it. They're used to messing with electronic devices. You don't have to yell at them, not yell, but you don't have to raise your voice if they were doing like a D15 where you would say, don't touch the caps. If they're doing the Ishihara, hey, don't touch the plates, don't put your fingerprints on the plates, the oil's going to change the colors. So you don't have to go through any of that negative stuff when you're doing computer assisted testing. As a matter of fact, you want them touching the screen. That's how they do the test. They like it. It's better for everybody. So here's an example of what it looks like doing computer assisted testing on a kid, and contrast this again with handing somebody a 100-year-old Ishihara color vision plate book and asking them to do it. Acquired color vision defects. So we've talked about genetic defects, okay? Genetic color vision defects, genetic defects, kids having genetic defects, okay? I'm done with that. We're not going to talk about color vision defect, genetic color vision defects anymore. I had to mention it because the title is Color Vision in Health and Disease. Okay, these kids are healthy. These people are healthy. Now we're done with that. Let's talk about what I really want to get into, and that's people that have ocular disease, systemic disease, neurologic disease that can affect their color vision, and I want to find out if that's what's going on. So we're talking now about acquired color vision defects. The first thing you got to know is so important is that 15% of the population has some type of acquired color vision defect, and it's almost comical to me how we spend so much time talking about glaucoma and macular degeneration and all these classes we go to on dry eye and this and that. Well, then that's all important. Glaucoma is an important thing. It'll blind you. But we also know that only 2% of the population is going to get glaucoma. Here we've got 15% of the population getting a color vision defect, and I would simply ask how many of us have been to classes talking about color vision prior to now. To me, this is definitely an underrepresented topic, and it is timely to bring it to the forefront now. So that's what we are doing. So you see all these little factoids down here on this column. The patients often are unaware that they have changes in their color vision. It could be real subtle. It would almost be like asking a patient, hey, do you have a nasal step in your left eye? Well, gee, doc, I don't know. I mean, I would say, when's the last patient that came in and said, hey, Hey, I think I've got a nasal step in my left eye, doc. Would you run a threshold visual field test and check it out for me? Okay, that's not going to happen. Just like the patient usually is not going to come in and say, hey, doc, I think I've got a mild blue-yellow defect in my right eye secondary to diabetes. Could you run an extended color vision test and make sure I'm okay? Okay, if you're waiting on that, then it's not going to happen. So the patient's not aware. The color vision defects can be unambiguous. They're nonspecific. They can be asymmetric, and they can change. Excuse me, almost like a visual field changing in a patient with glaucoma. Color vision defects can come and go. They can resolve. They can get more intense. It can go from one eye to the other, all kind of stuff. There's no rules. The only rules is that there's no rules. So you've got to be aware of all the non-rules that go along with acquired color vision defects. And you see again on the slide all the bullets for the diseases that can cause color vision deficiencies. There's plenty of stuff that can do this. So let's get into it. The first thing is we're all familiar with drugs. Drugs can cause changes in your person's color vision. The most common that most of us deal with is Plaquenil. Patients on rheumatoid arthritis and certain types of autoimmune disease where they're prescribed Plaquenil. We all know how we're supposed to evaluate the patient, their retina and their fundus, to see if there's damage from taking Plaquenil. And we all know that testing their color vision is one of the things that we're supposed to do to see if there's loss of function in patients taking Plaquenil. But it's not just Plaquenil. It can be any of these 300 drugs that you see on this slide. I mean, there's not 300 on here, but there's a bunch of them. And this is just a representative sample of the medicines and drugs that can affect a patient's color vision. So here's your start right here. How might this stuff happen? How might someone get a color vision defect? What's the pathogenesis? Well, almost always there's some structural damage that's occurring at some anatomical depth. It could be, like when I test the patient's eye, I generally try to go from the front to the back. When I'm testing the visual system, I go from the front to the back. Well, here we'll start at the front, the prereceptor. So the first thing that can happen is you can have the lens in the eye, the crystalline lens, start to change. It'll start to yellow. The index of refraction will change as the patient ages. And these changes can alter the transmission of visible light and alter the color vision. So the first thing that could happen as far as where's the damage, well, the damage could be in the front of the eye, kind of in the middle, where the lens is, so a prereceptor. It could be receptor cells, the red cones, the blue cones, the green cones, and their ganglion cells. So any disease process that can damage the cones and their ganglion cells can affect color vision. Well, the first thing that comes to my mind is glaucoma, but we'll talk about that in a minute. The third thing, postreceptor, retinal cortical neural pathways in the brain. There's multiple studies and plenty of evidence that shows that you can have damage in the pathways in the lateral geniculate nucleus. Glaucoma and other conditions, diabetes, can damage the brain and these structures. And I've just shown you that these structures are responsible for transmitting the chromatic information. And so if the transmission lines are messed up, well, the information is not going to get to the brain. The color vision will be abnormal. So you can have any damage at any of these anatomic levels that can produce color vision loss. The prereceptor level, the receptors themselves, or the postreceptors. And when you're trying to figure out, is the defect acquired or congenital, the easiest thing to remember is that genetic defects are always bilateral and always the same in each eye, whereas acquired defects can be different in each eye and be in one eye. So that's your easiest clue right there. Let's talk about the different kinds of things that can happen, the different kinds of color defects, the pathogenesis. The correct term is dyschromatopsia. So if a person is losing their color vision, or they have a loss of chromatic discrimination, that's the correct term, a loss of chromatic discrimination. So if the person is having a loss of chromatic discrimination and the main cause is they're getting older, this is why. So you have pupillary miosis, the yellowing of the lens, change in the density, the index of refraction. You can have short wavelength cone fallout, the blue cones. So those little bitty blue cones that are every once in a while, they seem to die off faster than all the other cones, the red and the green cones, for some unfortunate reason. So they're lost at an elevated rate in a lot of people. So these four things comprise the pathogenesis of the dyschromatopsia of aging, losing your color vision because you're getting older. The next thing, the one I just spoke about. Okay, we know all kind of stuff about this. We talk about this stuff all the time. So the dyschromatopsia of Plaquenil. And it's a whole different mechanism. I mean, it's about as different as you can be from what we just said with the aging. So the pathogenic effect of Plaquenil is this, it starts off the induction of lysosomal dysfunction in the photoreceptors and the RPE, the retinal pigment epithelium. And this lysosomal dysfunction creates abnormal metabolism. It leads to increased phagocytosis of the outer segments. It's a long cascade chain of events. I mean, I don't want to get too deep into it, but this is what's happening. Once the cells get damaged, the photoreceptor cells, you can see it on a spectral domain OCT as perifoveal thinning in the macula when you do the ganglion cell analysis. And once enough cells are damaged from taking this Plaquenil and the lysosomal dysfunction, the abnormal metabolism, then you'll start to lose your color vision. So kind of step 1, step 2, step 3, as far as how does someone lose their color vision taking Plaquenil, this is how it goes. The next big thing, and it's a big one, is glaucoma. So what you got to remember about glaucoma is all the modern studies say that glaucoma is not a disease that should be considered an eye disease, but it's a disease, it's really a brain disease. You think about the brain, and the optic nerve and the eye are simply extensions of the brain. And so glaucoma is a disease that affects the whole visual system, the eye and the brain. We know this from studies that excuse me, show that the lateral geniculate nucleus is damaged. You've got impairment of the ganglion cells in the outer retina. These bullets here, I mean, it explains it all. It's all true. So you've got to recognize when we're talking about glaucoma, we're not just talking about exclusively an eye disease, but also a brain disease too. What we know now, and we've known it for a while, is that color vision defects can precede visual field loss in patients with glaucoma. So there is a condition called the dyschromatopsia of glaucoma, the loss of chromatic discrimination that can be found in some patients with glaucoma. It's not all patients. Just like all patients with glaucoma don't have visual field loss, all patients with glaucoma don't have abnormal VEPs, all patients with glaucoma do not have retinal nerve fiber layer fallout, and all patients with glaucoma do not have color vision loss, but a lot of them do. And this generalized loss of chromatic discrimination, it affects 20–30% of the people with glaucoma. So it's not the majority, but it's not 1%, 3%, 5% either. So I mean, there's a big chunk of people. The people that have a loss of color vision secondary to glaucoma is just as big as the number of people that have low tension glaucoma, where you never measure the pressure above 21. It's the same size group of people. So that's a big group. And last, some patients develop color vision loss only when the glaucoma is real advanced. I've seen that. Everybody's different. There's no rules. So, the best thing is, since there's no rules, just kind of maybe test everybody since there's no rules. And you see the breakdown of color vision deficiencies in people with glaucoma up here in these little bullets. So, 20 to 40% of the people with glaucoma, okay, they're going to be normal. But you'll have blue, yellow here. There's going to be a kind of a mixed loss with 20 or 30% of the people. Some people are going to have a pure red, green. There's no rules, but definitely people with glaucoma can have a loss of color vision, and trying to figure out, does my patient have glaucoma, yes or no? Or if they have glaucoma, is the glaucoma getting better, worse, or staying the same, yes or no? An extended color vision test can be very important in helping me make that decision, where I'm not totally dependent on a visual field or totally dependent on an OCT scan of the nerve head, or even dependent on ERG or VEP testing. I mean, I do them all because there's no one that's really more important than the other to me right now. So here's some factoids on the dyschromatopsia of glaucoma. Next, we have the dyschromatopsia of diabetes. And this is a big thing here. This is really, really big. I don't know which is more significant to me, the patients with diabetes or the patients with glaucoma. Honestly, I think it's the patient with diabetes, where the testing is more significant. I'm doing more of it, and I get more benefit from it. The first thing, the reason why, is because chromatic visual disturbance, loss of color vision, loss of chromatic discrimination, however you want to say it, color vision defect, there's 10 different ways to say it. So a chromatic visual disturbance in association with this presumed hypoxia that precedes diabetic retinopathy occurs in 55% of the patients. So if I lined up 100 people that have diabetes, if they're going to have some abnormal findings, 55% of them can have a loss of color vision before I see anything wrong with them. And you've got to recognize now diabetes, diabetic retinopathy, really has two different subgroups. There's a vascular form of diabetic retinopathy, vasculopathy, which is what we look for. That's the way we've been trained. So we're always, when we have patients with diabetes, we do our thing, we do our diabetic eye exam, we dilate them up, look at the fundus, and the standard of care and the definition right now, unfortunately, of diabetic retinopathy is that you've got to see something. You're looking for hemorrhages, microaneurysms, exudates, retinal edema, capillary non-perfusion, fallout. So you're looking for something you can see, where the retina looks different. There's some vascular lesion. That's what diabetic retinopathy is, kind of, sort of, right now. Well, the recent research says that it's more than that. The recent research says diabetic retinopathy has a vascular component called vasculopathy, but also has a neurodegenerative component that you cannot see. So you can have a patient that has 20/20 vision. They've been diabetic for 5, 10, 15, 20 years. They got 20/20 vision. You dilate them up. Everything looks fine. You don't see anything. They are totally normal. The visual acuity could be 20/20. It might be 20/20 minus, it could be 20/25, but it won't be bad. And you would then examine that patient and make the assessment and diagnosis of no diabetic retinopathy, no ophthalmic manifestations from the diabetes. This person is totally normal. Go to the next patient, see you later, send the report to the doc, it's all good. What I'm telling you is that it's not all good all the time. And that some of these patients, if you start testing them functionally, if you start doing color vision testing, visual field testing, dark adaptometry, ERG testing, many of these patients will show deficits even though they have normal visual acuity and a normal appearance of the retina. And what these guys down here in this ARVO Investigative Ophthalmology Vision Science article said is that their studies show that you can have this loss of chromatic discrimination, a color vision defect, in a whole bunch of people that look totally normal. So if you're trying to figure out if somebody's got something wrong with them, do you just look at them now, or do you actually start running some functional tests to see if they've got something wrong with them? And an extended color vision test is one of the quickest, easiest, least expensive ways to start that process. Additionally, if they actually have diabetic retinopathy, so if you see anything, one dot, one hemorrhage, one exudate, anything, 55, 65% of those patients are going to have color vision defects. And of that group, almost 90% of them are going to have a blue-yellow defect. And we just talked about why. Because of the low redundancy of the blue-yellow pathway right here. See, only 2% of the cones are transmitting blue-yellow vision. So only 2% of the fibers in the neural pathways are transmitting this vision. If they get diabetes or glaucoma, any other stuff, it kills the blue-yellow color vision so quick. That's why it's always, not always, but that's why it's usually the most common color vision defect that you see in ocular and systemic disease. So here we are, diabetes, the dyschromatopsia of diabetes. I just can't stress how important it is to consider evaluating your patient's color vision if they have diabetes. You will start to see evidence of retinal neurodegeneration in the appearance of, and coinciding with the normal appearance of the retina. It's really a big deal. So the dyschromatopsia of diabetes, big deal. Optic neuritis. Optic neuritis was the one thing I remember them talking to us about as far as color vision loss, acquired color vision defects. Now I started optometry school in 1979, so it might be different now. But I remember the optic neuritis thing. I remember them talking about Kohler's rule, the red-green stuff always. Well, let's start over. Okay, so let's start over with optic neuritis. It's mostly in the context of us looking for patients with multiple sclerosis. That's the most common thing. But I've had patients with optic neuritis where we did all kind of tests on them, did all kind of MRIs, and did not diagnose multiple sclerosis. But generally, that's what this is associated with. So it's the second most common cause of systemic inflammatory infection. It's usually unilateral, usually young people, usually women. And then, all the classic things we've already learned about: pain on eye movement, pupillary defects, decreased color vision, abnormal VEP waveforms, visual field defects. All of this stuff can occur when you have patients with optic neuritis. Now, here's the thing. I've been in practice long enough to where I've seen people with acute optic neuritis come in, and it's pretty easy to recognize it once you've got a few under your belt. The tricky part would be some new patient that you're seeing that maybe had an attack of optic neuritis 3 years ago, or maybe had an attack 5 years ago, or maybe had a subclinical attack where they knew nothing about it, or maybe they don't know they have multiple sclerosis, or maybe they don't know they had some kind of systemic infection or inflammation. They may not know anything. They may think this eye is supposed to be like that. They might think their last eye doctor didn't do a good job on the left eye. Who knows what's happening? They usually don't. You got to figure it out. So again, the ones that are easy, the guy comes in or the lady comes in and she says, hey, I woke up this morning, I can't see out of my left eye. Okay, it'll take me about 10 minutes to figure that out. It's the patient that comes in that's new or haven't seen in 6 years, and one eye looks different, or the nerve head is pale, or something gives me a clue to make me think something's wrong with their optic nerve, and then I get into it. Well, as we all learned, there is a dyschromatopsia associated with optic neuritis. And it's a real goofy one. Number one, there's no single defect, and that's what you'll see with these acquired defects. Remember the slides. There's no rules. It could be red, green, it could be blue, yellow, it could be mild in one eye, it's severe in the other. One eye could be normal. There's just no rules. What's key about optic neuritis is that at the time of the acute demyelination, when they got that first attack, most of the time the defects were blue, yellow. After that, and it seems like it's like 6 months, it's like the nerve kind of recovers and some stuff gets better. And then if you measure their color vision again, a lot of times it'll be different 6 or more months later and turns into a red-green defect, but it might be the same because remember, there's no rules. Here's the big thing about optic neuritis. And this was a study that came out of the Indian Journal of Ophthalmology. So you've got this group of multiple sclerosis patients without a history of optic neuritis, because you certainly could get MS without having optic neuritis. So you got a whole group of people with multiple sclerosis, a history of no optic neuritis, so they got no bad history, 20/20 acuity. And so the doctors are trying to figure out what tests can they do to detect subclinical visual pathway involvement. So we know the patient has multiple sclerosis. We know there's a high chance that they've got some demyelination somewhere in the brain, because that's what's causing the thing. It's just depending on whether it's in the brain connected to the part that's in the visual pathway, or some other part of the brain. But we know it's brain damage. So if I'm seeing that patient that I know has MS, and I want to tell that patient, ma'am, are you normal, or has anything bad happened to you? What test would I use to see that? How could I pick that up? Well, these guys did that study, and what they found is that the color vision test was the most sensitive. And 70% of the patients that had this subclinical optic neuritis had abnormal color vision. 55% had abnormal VEPs. Only 30% had that retrograde degeneration that you see on an OCT scan, where it's all red, that's associated with that axonal degeneration, where the brain damage starts in kind of the midbrain and then moves forward into the eye. That's retrograde degeneration. So color vision is the most sensitive test, at picking up subclinical visual pathway involvement in patients with multiple sclerosis. I got to tell you, until I started preparing for this type presentation, I didn't know that. Now, I don't see a lot of patients like this, but I see several a year, and it's important for me to know this information. And now I always include extended color vision testing in my diagnostic workup to take care of these patients. So let's talk about color vision testing, since we talked about diagnostic workup. So first thing you got to remember is that abnormal color vision is a non-specific finding. So it can occur in almost anything. It could be any variety of ocular, neurologic, genetic conditions. So just because someone's got a red, green, or blue, yellow color vision defect, that is not diagnostic of anything specifically. You can't do that test and say, okay, well, this person has glaucoma. You can't do that test and say, well, this person has diabetes. You can do the reverse, though, and maybe if the person has diabetes and they complain about their vision, you could do the test and confirm or deny it. So, I mean, it goes one way but not the other. When we're testing their color vision, the first thing you got to immediately know is don't even think of using these tests here. These are screening tests. Again, I'm still mad that they made me buy that thing 38 years ago. They made me buy that Ishihara pseudo-isochromatic color vision plate book that's 100 years old that won't pick up hardly anything. It's a paperweight. I think I gave them all away. It's a screening test. It's worthless. The next one, the American Optical HRR plates, designed to do the same screening, picking up that 8% of young white males that are red-green deficient or grown white males. And it has plates for the blue-yellow testing, so it's definitely more comprehensive than the Ishihara, but it's still a screening test. What I want to concentrate on and talk about is extended color vision testing. So extended testing is much more sophisticated, and it's used to assess the integrity of the retina, the optic nerve, and the visual pathways. The most common and the least expensive of the extended color vision test is the Farnsworth D15 panel, the test that we do with the caps, where you move them around in arrangement. It's a color arrangement test. It has some value, very little. The test was designed in the 1940s to screen railroad engineers and conductors so they could see the signals on the railroad tracks. I mean, if you think about us trying in 2017, trying to take care of our patients and figure out if they have something wrong with them and try to make decisions about what to do about it with a test that's 70 years old that was designed to test railroad conductors, we could probably do a little better than that. But that's the most common and the least expensive. And as I've been lecturing on this topic for the past few years, when I ask doctors in my classes, I'll say, hey, who's doing any color vision testing? And hands will go up, and I'll say, well, what kind of test are you doing? And they'll say, I'm doing a D15. I'm doing a D15. Man, I'm on top of it. And I'm like, well, maybe. So not really. The D15 is better than those screening tests, but is not nearly sensitive enough to pick up the stuff that I'm looking for on my patients with eye disease. So to me, that's a paperweight. Let's move on. You could go to the Farnsworth 100 hue test, which is the same type of arrangement test. With 100, it's got 85 caps instead of 15. I don't know why they call it 100. It's 85 caps. And it's a real good test. It'll pick up practically anything. The only problem is it takes an hour to do, and that's a big problem. And then it might take you 30, 40 minutes to score it if you don't have some kind of calculator sitting there set up to do it. So to do the whole thing, it'd be an hour and a half, 2 hours. I'm not going to do that. I don't care. I'm just not going to do it. I don't care how good it is. There's no test in my office that's going to take me an hour and a half or 2 hours to do. I'm not doing that kind of test for various and sundry reasons, even if it works. And this one works real good. The third one is the anomaliscope. I would almost say the same thing that I said about the 100 hue test. The anomaliscope is historically referred to as the gold standard, so everything is compared to that, and that's fine. I have been in literally hundreds of optometric practices in my career. I can count the number of anomaliscopes I've seen on one hand. Probably the only time I see one is when I visit an optometry school clinic, and then it's not being used. So if anyone wants to say, hey, I'm gonna test my patients with an anomaliscope, yeah, okay, go ahead. But I have not seen that. Again, it works great, and if you got one, hey, you're there. If you don't have one, I would not get one. What I would get was one of these. So what I want to talk about is some computer-assisted testing. And there's several companies in the country and in Europe and Japan that make computer-assisted color vision testing. This is a picture of one of them. It's called the Color DX. Software, it's software that you put on a pad or a computer. So you just buy the software and stick it on a pad, an Android or something. You see it in use here. It's real cool. It's self-administering. The patient does the test. You just kind of stand there and look at them while they're doing it. The computer software scores the test. It's adaptive, like a threshold visual field, to where if they miss some of the plates or miss some of the colors, the instrument goes back and rechecks it. So it's adaptive in that sense. And it's been validated by the Naval Aerospace Medical Institute as comparable to an anomaliscope, so that's good enough for me. I don't have to question the validity of the results. It's already been tested. So this is a newer, and I would say better way to measure your patients or test your patient's color vision, so with computer-assisted color vision testing. The second big computer-assisted test is the cone contrast test. This test is really, really slick. This is real cool. I like this one too. I like the other. I mean, they're both good. They're different. The computer-assisted test was developed in cooperation with the Air Force, and it's a cone-specific contrast sensitivity test. And what it does is it flashes the letter, and then it flashes the letters, you know, like C, B, A, whatever, in different colors. And as it flashes it, almost like a visual field machine, it decreases the steps of contrast until you can't recognize the letter anymore. So it'll flash a letter C in a bright red that's easy to see, and then it'll make it a little dimmer and a little dimmer and a little dimmer until you can't see it, and that will be your threshold. So it establishes this threshold, and it produces contrast sensitivity scores where you can measure that. That's how it produces its output, and you can determine the patient's color vision like that. I've seen it in use. I don't have one yet. I may get one. But I like it. It was quick. It was easy. It looked like it was really accurate. It wasn't hard for the patient. I'd recommend it. So there's two big computer-assisted tests, the Color DX and the Cone Contrast test. I'd recommend either one. 10 times better than the other test. Just to give you a little bit more info, the Color DX produces an output that looks like this, just so you can see it. Where you see all this stuff is all computer generated. The doctor's not doing anything. And what makes a test extended, and why the D15, the D100, the anomaliscope, the Color DX, the Cone Contrast test, these are all extended tests which are reimbursable as opposed to screening tests which are not. So to make the test extended, it has to determine the type of color vision deficiency, protan, deutan, or tritan, and it has to grade the severity. So it's mild, moderate, or severe, almost like assessing glaucomatous damage. So if you can't grade the severity, it cannot be reported as an extended color vision test. That's a key thing. And again, most of these computer tests, they take 10 to 15 minutes to set up and perform. How would you report this service? It's a test. It's no different than visual field testing or fundus photography or any test that we do. And just like any test that we do, it may be reasonable and medically necessary based upon abnormal symptoms, signs, illness, injury. It's nothing special. The only thing special about extended color vision testing is historically very few people are doing it. That's the problem, and that's why I'm talking about it. As little as 5 years ago, I got a hold of the Medicare statistics for utilization, and in 2011, Medicare paid a total of 5,000 extended color vision tests for the entire year. And in that year, I billed 50 tests to Medicare. So by myself, I did 1% of the national total of extended color vision tests, which I think is an abomination. That's crazy. I mean, it makes me look bad. It makes everybody look bad. I don't want that to happen again. Fortunately, it's not happening anymore. That was when I started lecturing about color vision. I said, hey, everybody needs to, come help me, please. Okay, I'm looking funny out here by myself. Please come help me. And fortunately, lots of doctors have started to come and help me and not make me look so funny. So I don't know what the recent numbers are, but I know it's a lot now. I mean, I know individual doctors that have reported and performed hundreds of these tests per year. I probably do, I don't know what my numbers were in 2016, maybe 120, 130. So it's not like I'm doing it every day, all day, but it's something I do regularly to take care of my patients. You can see the cost of the different tests. There's a pretty wide range, going as low as $250 for the D15 to as high as $11,000 for an anomaliscope, and practically anywhere in between. And again, I'm not giving a commercial for one product or another. You can get whatever you want, whatever's best for you. If you think you want to start with a D15 and all you got is $200, hey, knock yourself out. Start doing something. But if you want to do it for real, I would pick any of the others beside the D15. You see the reimbursement is pretty good. For CPT code 92283 in Texas, the Medicare fee is $57. That's the highest I've ever seen. The lowest goes down to about $36 or $37. Most major medical insurance companies are in the low 40s. So Medicare is the highest fee, but it's always a decent fee. And I don't really care about it. I'm not doing the test to make money. If it's $36, I'm not going to make a living doing a test for $36. I'm doing the test to see if there's something wrong with my patient and trying to make decisions with the information. Well, I get paid to do that. I mean, that's the way it works. I don't have any problem with it. But it, it is, a financially positive return on investment if you perform the test. I'll just leave it at that. So treatment options. So let's say we've done all this stuff now. You've got your patient. You've differentiated whether they were healthy or abnormal. You were suspicious about something, and something they said, something you saw, something in their history, created the medical necessity to where you ordered and performed an extended color vision test, and you determined that they had a color vision defect in one or both eyes. So what do? So what? I've given lectures where I'll talk to doctors. A good example is specular microscopy, where I'll give a lecture and talk about specular microscopy and how it's so important to know the health of the endothelium and how you can do all kind of stuff. And then I'll have doctors that'll come and say, Dr. Thomas, what's the benefit of doing specular microscopy on a patient? I can't do anything to make their corneal endothelium better if there's something wrong with it. I can't fix it. So what's the benefit of finding out if it's normal versus abnormal since I can't fix it? And I almost don't know what to say when doctors, talk to me like that, because it's so wrong. I always respond. I'll say, doctor, if your mother had an inoperable brain tumor and the doctor gave her 6 months to live, would you want to know that, or would you want the doctor to withhold that information and pretend nothing's going on? Well, of course, we all know the answer. You'd want to know. Well, doctor, if your patient had a color vision defect, would you withhold that information, or would you tell them, even though you can't fix it? Okay, well, the answer is the same. And in this scenario, it's not an absolute that you can't fix it. Okay, let's look at our treatment options. So let's say we've got acquired defects. Well, first thing, you got to differentiate if it's genetic or acquired. Just as an aside, I don't have a slide on it, but if it's a genetic defect, I've actually had some mild success using the Chromagen product, those filtered tinted lenses, where you kind of do a mix and match and try to find some tint that enhances their vision or enhances their sensitivity or their discrimination. I've done a few patients where it seemed like it helped them. So, I mean, if you actually had some little kid and you picked up a red-green defect, it's not the end of the world. You might be able to make them improve their color vision by prescribing the Chromagen product, but that's genetic. So let's talk about acquired. So if it's acquired, then you're going to figure out if it's in one eye or, is it both eyes? Does it come and go? But most importantly, you want to figure out, if you don't know, the primary condition that's producing the color vision defect. Remember, the title of the lecture, Color Vision in Health and Disease. So we went through those slides talking about all those dyschromatopsias, dyschromatopsia of aging, dyschromatopsia of diabetes, dyschromatopsia of glaucoma, dyschromatopsia of plaquenil, dyschromatopsia of optic neuritis. Okay, there's others. So once you've made the correct diagnosis, so what if it's the dyschromatopsia of diabetes? And then your last bullet there, prescribe a treatment program. Well, I'm not going to prescribe some insulin. I'm not going to give anybody any metformin. What can I as an optometrist do as far as prescribing a treatment program to my diabetic patient that has an asymmetric color vision defect? Well, the first thing I could tell them is I could say, hey, Mr. Jones, hey, I got a little news for you. You thought you were okay? Well, you're not quite as okay as you thought you were. You're starting to lose your vision in the left eye from this diabetes. Fortunately, it's mild, and it's only affected your color vision so far, you can still see good. Your visual acuity is still okay. So that part of your vision is okay. But this part of your vision that's responsible for the color discrimination, that part's starting to get messed up. I believe your diabetes is not under good control because of this finding. And so now the case presentation at the end of the exam completely changes. And I go into that optometric thing of I have a nice 8, 10, 12-minute conversation as opposed to a 3-minute conversation if they were normal about, hey, what did you have for breakfast today? How's your diet going? Give me a little bit of idea how your exercise is doing. When did you see your internist last? Are you taking your pills every day? How's that going? You're not missing any of your shots, are you? It changes the whole conversation if you've got an abnormal finding on the color vision test versus a normal finding on the color vision test. It affects everything. It's fundamental. And the same thing would happen if it was a visual field, dark optometry, ERG. I'm using color vision because that's what we're talking about, but the concept and the context is the same for all of our other diagnostic tests. So the key thing is that if indeed you determine that your patient has an acquired color vision defect, the main thing is trying to figure out what's causing it and then doing what you can to make that better. And there's all kind of stuff we can do. If it's glaucoma, I might treat the glaucoma more aggressively. If it's diabetes, I'm starting to get into the nutritional component with the diabetes. We're all real heavy with our nutritional stuff with our macular degen patients and our dry eye patients. I've been reading a lot of Dr. Paul Chauce's articles here the past 6 months, and it's incredible the stuff he's doing with nutritional supplements in his diabetic patients, and I think I'm going to jump on board with that, and I'm going to head down that road as we move forward in 2017. So it's really a big deal, checking the patient's color vision, checking it properly with an extended test. If you can kick it up a notch, going with a computer-assisted test, and knowing what all this stuff means and how you put it all together. So there is a very important component that many of us are missing that I want to get into, where we incorporate extended color vision testing into our diagnostic protocol to help us figure out, is my patient okay, yes or no? And if the answer is no, what am I going to do about it? So I want to leave you with that. Think about it. Review the procedure, review the program. I'll be available for the next hour for any kind of questions. I'll just be sitting here waiting on you. Thanks for listening. Hope everybody enjoyed it. Hope everybody learned a little bit of something. Give me a call or send me a post on OD Wire and I'll get back to you. Thanks, everybody.